So good afternoon, everybody. Welcome to this Policy Talks and a very special Policy Talks today. I'm just watching my attendees list and people are just joining the room right now. So I'm going to give it just a few more seconds as people join us. I'm glad that people are taking some time out of their day to be with us and to talk about this topic. It's incredibly important, and I'm very grateful to our panel for being here with us. So as people trickle in, I just want to take a moment to introduce myself. My name is Warren Mabey. I'm the director of the School of Policy Studies here at Queen's University. And it is my great pleasure to host you for this lunchtime talk. Before we begin, I do want to acknowledge that Queen's University sits on the traditional territories of the Haudenosaunee and the Anishinaabe peoples. And it is our privilege to be able to learn and to meet and to study on these grounds. Because we are virtual and we have people attending from all across the province and indeed across Canada, do take a moment to think about the traditional territories where you yourself might be situated as we enter into this talk. I'm going to hand over the hosting duties primarily to my colleague, David Walker, and David is going to introduce our panel. So David, without any further ado, I'm going to just pass to you. Thank you.
Thank you, Warren, and welcome everybody. Hello to everybody near and far. To our children watching, some not seen or hugged for over a year, you have my love. To those grandchildren who've logged on as an academic hour for school, thank you. I know Jack has for sure. He's in senior kindergarten in Toronto. So Jack, pay attention, please. 1 year ago, almost to this day, I and my friends addressed the topic of a novel coronavirus that had been reported in Wuhan, China. We discussed policy options in light of previous challenges such as SARS, which a number of us were involved with. You can see what we said then on the website of the School of Policy Studies. It's a bit unnerving, actually. Life in Kingston then was normal. Since then, much has changed. Dr. Buttemer's had her baby. We were worried she would have the baby during her last presentation, but she didn't. Kieran has demonstrated what a high-functioning health unit looks like. A very high-functioning health unit in southeastern Ontario with some of the lowest case numbers in North America. And Gerald, well, Gerald's CV caused the server to crash when he submitted his annual report to the dean the other day. So humor aside, because this is a very serious matter, we thought it might be useful to look again through our policy lenses at what we've learned during the past 12 months and how those lessons can inform policy going forward. In my personal view, much of what we've learned in the past has reinforced previous lessons rather than reinventing them. The need for surveillance, protection of the vulnerable and those who care for them, infection prevention and control measures, dissociation of public health from political communication, amongst others. COVID has stressed our global society. It's caused significant human damage to health and well-being. 100 million people have been infected, at least, and 2 million people in this world have died. COVID has harmed our economies and our social structures and challenged our core values. This pandemic is a trend accelerant. It's changed the way we care for the sick. It has shown the magnificence of the scientific endeavor when deployed, and it will leave a trail of differences in how we work, play, think, and educate. COVID is a magnifier of our pre-existing weaknesses and shortfalls. COVID's victims are disproportionately the marginalized, the racialized, and the poor. Those with mental illness and addictions are dying at unprecedented rates. Those who labor in critical yet undervalued jobs have borne the brunt. And the way in which we care for our elderly has been shown to be abysmal. And we've learned about cold chains, we've learned about procurement, vaccine wars, geopolitics and nationalism, realities that may be precursors to how the world will work once we've equilibrated our relationship with this virus. So as those involved with or interested in public policy, I would argue that we have an obligation to operationalize what we've learned and to use this burning platform to accelerate those changes. My friends have been kind enough to reconvene today, and I will introduce them now all together, and they will speak in this order. The aforementioned Dr. Gerald Evans, Chair of Infectious Diseases in the Department of Medicine at Queen's, full professor at Queen's, and Director of Infection Prevention and Control at Kingston Health Sciences Centre, has many, many provincial and national roles. He'll speak about the behaviour of SARS CoV-2, remedies, and vaccines. And Dr. Kieran Moore is a professor in family and emergency medicine at Queen's, and he's Medical Officer of Health. Our local media call him our Chief Medical Officer of Health in Kingston, Frontenac, Lennox, and Addington, served with me on the SARS expert panel in 2003. And as I mentioned, is unarguably the highest performing health unit in Ontario. He will address the public health policy framework. And Dr. Samantha Buttemer is qualified in family medicine, public health, and preventive medicine, holds a master's degree in public health from the London School of Hygiene and Tropical Medicine, and is adjunct faculty in health sciences and policy studies at Queen's. And she will consider the direct, indirect, and collateral ramifications of COVID. So welcome to the panel, and we will ask Gerald to take over from here.
Thank you very much, David. So being the medically trained guy I am, here come the slides. And I'm going to zipping through them as expeditiously as possible to allow lots of time for questions and things. So really, I'm going to talk a little bit about the science of COVID-19 in many aspects, and at the same time do a lot of mea culpas around a little bit of what happened and what we discussed last year. I like to start off with this slide because I think it really stems into the idea that we, in a pandemic situation, in stress and anxiety in society, are always looking for answers. We like simple answers because they're a lot easier to process. And unfortunately, we're learning that sometimes they're wrong. The complex answers, which are the real answers, are the right ones, but unfortunately, it's not a path that's well tread by many. So back when we did this talk last year, the WHO had declared a public health emergency of international concern around what was then called 2019 novel coronavirus. And that's because it had spread outside of China, and their view was that this was a unprecedented occurrence. So we were kind of hopeful then. We knew it was going to be a problem. This is an important announcement that they made. Little did we know, though, that we were not going to be so hopeful, because by March 11th, they had declared it a pandemic. The good news is it is the virus that I showed you a year ago. It hasn't changed. This is the first electron micrographs that were taken of the SARS CoV-2 virus with its traditional spikes. Here it is in isolation, and here it is in lung tissue. So that hasn't changed. We talked a lot about transmission dynamics of what was then called novel coronavirus interstitial pneumonitis, and we got a number of things right off the start. We knew about the incubation period. We had a very good idea about the basic reproductive number, which is a number that does fluctuate. And we knew that it was primarily a large respiratory droplet spread infection like influenza, but we were still wondering about other modes. There was a question about asymptomatic transmission, and I said at the time it was unknown. And I put this up in partial defense of my view on this at the time, which was that Dr. Tony Fauci, which most people would say certainly has extremely more gravitas than I do, thought that asymptomatic transmission was never going to be a driver of the outbreak. And I'm going to give you some numbers in a few minutes. But if Tony Fauci and I felt the same way at that time, I feel like I'm in good company. So what do we know about SARS-CoV-2 in generally speaking with regards to the illness and its onset? So this is a graph that shows the rise in viral load that one sees in a patient. We now know that up to 2 days prior to the onset of symptoms in those that become symptomatic, virus is detectable and is sheddable and can result in infection, although not so much as the high viral loads that we tend to see in the first 5 days of infection before they begin to drop off in most people who recover. This is the period we can find culturable virus, which causes transmission, and that's what is very relevant. What we do know now about asymptomatic transmission has been well worked out in a number of meta-analyses that have been published. This is a particularly good one that came from an Australian group, published in JAMI, and they basically showed with an extensive meta-analysis that about 17% of cases are truly asymptomatic. So that's to distinguish them from pre and post-symptomatic individuals. So asymptomatic cases exist in COVID, and clearly they have an opportunity for transmission. How relevant is that transmission is that we know that although it can result in transmission, the asymptomatic transmission itself is 42% lower than what you see from symptomatic transmission. And these are again, from that same study looking at the relative risk ratio. So asymptomatic transmission can occur. It may be playing a part in this pandemic without question, but the exact amount is still a little bit out there. So let's talk about the 5 C's of COVID transmission that we do know about: closed settings, close proximity, crowded spaces, continuous exposure, and cold. And one of the most fascinating things about this particular issue is that this is a little graph that shows you when typical respiratory viruses pop up, and human coronaviruses, the ones that existed and have circulated around humans before SARS CoV-2, in fact, peak between December and March. And this virus is behaving exactly the same. And this second wave is, in fact, corresponding when we see coronaviruses pop out. So something to learn from past information. This is another pictograph that I like to show, which is essentially showing the relationship between humidity and temperature. Temperature going up here, humidity going up here. And this is a relative reproductive number effect of COVID-19. So when it's cold and dry like we are now, there's an increase in the reproductive number, whatever might exist at the time in whatever jurisdiction. When it's hot and it's humid, you get actually a reduction. So this virus is behaving a lot like all coronaviruses. The other thing we now know about COVID-19 transmission is it is over-dispersed. It is heterogeneous. And this is a nice graph from a study that was done in China, which showed that, in fact, only a small portion of people end up resulting in the most transmissions. So in this case, the number of secondary transmissions in about 80, and then if you add this 10%, 90% of people either accounted for no transmissions or only one transmission, but a small number of people accounted for a large number of secondary infections. So this over-dispersion, which has been well described with other infectious diseases, is definitely at work in COVID-19 and is likely one of the reasons why we see super spreading events. So the current evidence regarding route of transmission is that you need to be in close contact or proximity, and that can be prevented through physical distancing and, of course, masks, which I'll talk about in a second. Transmission at long range is actually uncommonly observed. So this is what is referred to perhaps as airborne transmission. And I'll talk a little bit about why that's relevant. There are rare exceptions. Long-range transmission has been seen in experimental conditions, and you can see and report, and there have been reports of cases where it's occurred in an indoor setting where, ventilation flow and air conditioning has contributed to that spread. This is really important because airborne transmission, which is what we see with diseases like measles and varicella, is due to the suspension of small aerosols that can extend far out from an infected individual and produce an infection either at a distance or over time if they were in a small room. What we know about aerosols with COVID-19 is that it's these short-range aerosols, which again are related to close proximities. Here's the ballistic droplets, here's the short-range aerosols, and they contribute to that transmission. So this is true airborne transmission. This is not. And really with COVID-19, the efficiency of airborne transmission is actually very poor. It can happen, but it's rare. So that's uncovered for us a really important concept, which is that the differentiation between droplets and aerosols is kind of an anachronism. We've always separated them out in infection prevention and control, but in fact, they represent a continuum. And short range and long range aerosols contribute differentially in the transmission of this disease. And we know that aerosols can lead to environmental contamination, which may promote fomite transmission, again, a means of transmission for COVID-19, but not a common one. This is one I totally blew, and this is actually from my slide from last year. And I said, this is not the correct response to 2019. Man, was I wrong. This is exactly the right response. And in fact, we know that wearing a mask is important. It provides source control to the person who might be wearing it, who's infected, so they're not expelling large amounts of infectious droplets and aerosols. And it protects, of course, the wearer of the mask in getting infection if they're close to or adjacent to someone who's infected. This is really important because we know socially this is what we were before COVID-19. This is what Dr. Walker and his grandchildren were used to, lots of connectiveness. When we first got into this, we said, wow, lots of masking, let's do bubbles. And if we did that, we would actually be so separated that the virus would peter itself out. and it would never continue on. Unfortunately, what we've seen is that mask use is not 100% and bubbles aren't. And so with 90% mask use, like we see in some countries like South Korea or here in our own public health unit, in fact, very little transmission goes on, and you can kind of keep it at low levels and keep it under control. If you go to Europe, where mask use has been projected to be about 50 to 60%, lots more transmission. And in the US, where mask use is so variable and actually quite low on general, you can see you're getting a network that looks much better at continuing transmission and high levels of transmission. Let's talk a little bit about IPAC. I said this, not this. My graphic didn't work too well here. And actually, we were probably pretty right. This nurse is wearing a respirator, a mask, and has appropriate PPE on. So what we know about transmission in the acute hospital setting is that it requires close contact and proximity. And what we've seen is that with consistent droplet and contact precautions, we have not seen a lot of transmission of COVID-19. The issue of short-range aerosols is important, and in fact, we now recommend, based on aerosol-generating medical procedures or proximity to a patient, that you need to consider using an N95 respirator. But the role of long-range aerosols, airborne transmission, is almost certainly a minor one as we look at the acute hospital setting. So there have been outbreaks in hospitals. What's going on? I'll give you a hint. It's not the type of mask you wear. What we know about, and this is what one of my colleagues who told me about an outbreak in a Toronto hospital back in June, is that outbreaks occurred when there were break room and common areas where staff were not using physical distancing. They decreased their mask wearing because they were eating and drinking and socializing. There was poor cleaning and decontamination. And even out on units, there were PPE lapses in donning and doffing, and there was incorrect use of PPE. For instance, an N95 that's not fit tested is not really a good N95. That was further borne out by what we saw just in the last couple of months of 2020, when there was a large outbreak at London Health Sciences Centre. And again, PPE violation and lapses, staff eating meals unmasked in close proximity. So all of those actually lead to acute hospital sector type transmissions of infection. But when used properly, droplet and contact precautions with occasional use of N95s with aerosols effectively keeps acute hospital workers relatively safe. So our recommendation continues to be medical masks. They're good as equally effective in the routine care of management of patients. But if you have an AGMP or you're in close proximity to patients who's quite sick and coughing, difficulty breathing, then yes, N95 would be appropriate, remembering it should be fit tested. This is really important because one of the challenges I've had as an IPAC director is dealing with numerous specialty society and statements from unions about the role of things like N95s. And again, this has been really challenging because every time I hear about it, I have to sort of address it and then present what we know in the way of evidence. And I don't fault them. Specialty societies and unions represent their members. So they have something called advocacy bias. They're first and foremost advocates for their members. So of course they're going to push for what they believe to be the ultimate in protection. But we know that there's other forms of cognitive bias that come into belief or come into range. Belief bias or hindsight bias, which is they've heard about reports from other places. Early on in the pandemic, we had all the terrible reports out of Italy, Spain, and New York City. So that led to, again, move towards that precautionary principle. There's confirmation bias. You look at data from aerosol scientists, they say airborne, that's confirming your own thoughts. You're going to ignore some of the other data. And then there's this sort of neglect of probability bias, which has been particularly a problem for us here because Dr. Moore and his colleagues at Public Health have done an amazing job keeping our community prevalence low. So that has a direct bearing on what we do within the hospital. Quickly, I'm going to switch to talk a little bit about medicine. I showed this slide a year ago. It looked like a respiratory disease. Now we know that, in fact, this is a multi-system disease. And we're hearing lots now about neurologic involvement, systemic involvement, including thrombosis, the effects on the heart, effects on the GI tract, COVID toes as an example of skin involvement. So it's a more complex infection and disease than we thought. And we now know, and I showed you a previous graph with this rise and fall in viral load, that illness can evolve into many different forms. The majority of people have mild to moderate illness, especially younger individuals. Severe illness and critical illness, though, begins to appear in older people and some of who may be at risk. And that can be associated with actually a change in that viral load course. A year ago, we talked about what's the medical management? Well, supportive therapy. It's a viral infection. We've come a long way. This is now a brief overshoot of what medical management is in January 2021. We have antiviral therapies, variably effective. We've got some antibody therapies, again, which have variable effectiveness. We have anti-inflammatory therapy in the form of drugs like dexamethasone, which has been dramatically useful in reducing some of the morbidity and mortality in individuals who become very ill and require admission to an ICU, for instance. So we don't have to do much oftentimes in mild disease and pre-symptomatic disease, but in severe and critical illness, we have lots of interventions. The BMJ's done a living systematic review of drug interventions for COVID-19. I implore you to, if you get your copy of the slides, go to that site. They've done a beautiful job of tracking all these proposed therapies for COVID and put them into a nice framework of whether they're beneficial or not and what the certainty of the evidence is around it. And right now, basically the best things that we got are corticosteroids for mortality and mechanical ventilation, and basically some antibody therapies. Some of these other ones are really not really convincingly useful. I'm going to finish off fairly quickly talking about vaccines. And one of the most fascinating things is some of the stuff that was mentioned back a year ago has come to fruition, which is the speeding up of the vaccine development pipeline. Back in the old days, it took us 10 or 15 years to move treatment, like a vaccine forward. What they've done with SARS CoV-2 has dramatically increased that. And less than a year after it was described, we now have available vaccines, 2 now approved in Canada, 2 close to approval in Canada, and many others that are approved in other parts of the world. So this has been a dramatically important part of the science of COVID. Lots of different platforms have been looked at. I'm not going to, it's a busy slide, but I want to draw your attention down here to two forms of vaccines that we really didn't use until COVID came along. One is mRNA vaccines, where we inject you with a little template of the spike protein mRNA. You make the mRNA in your cells, express it, and bingo, you get an antibody. And then this, the other one here is the adenovirus vector vaccines, which Johnson & Johnson and AstraZeneca, Oxford have developed. And again, giving a little DNA template in a virus, which can then make you make a spike protein you make an antibody against. But all of them basically made so that you make an antibody against this spike protein, which is what attaches to you to create infection. Lots of interest now in understanding the difference between protective immunity, sterilizing immunity, and transmission immunity. We know the current vaccines provide protective and sterilizing immunity. We're hoping they provide transmission immunity, because that'll eventually lead to herd immunity if we get enough people vaccinated. These vaccines are exciting. This is a graph of the Pfizer vaccine. This is the incidence of COVID. Here's people who got the placebo. Here's people who got the vaccine. Very dramatic, impressive efficacy of 95%, approaching what we see with measles vaccine. Here's the Moderna curve, very similar. Here's the placebo group. Here's the vaccine recipients. Huge separation, 95% effective. Here's the Oxford AstraZeneca vaccine. I got to look at this one a little bit differently. This is actually the vaccine recipients here, and here's the ones that got the placebo. In this case, was a meningococcal vaccine. But again, very significant separation of these curves. The other thing we know is these vaccines are incredibly safe. The Pfizer vaccine, we've now got data from almost 2 million doses given in the States, in which only 21 cases of what was really kind of mild, in most cases anaphylaxis, being induced. So giving us a rate of about 1 in 90,000 to 1 in 100,000. With Moderna, we're seeing the same sort of thing. They've given 4 million doses of Moderna, only 11 or 10 cases described, and all of them occurring very quickly. So that gives us a rate of 2.5 cases per million doses. This is almost unparalleled in terms of vaccine development to have that minimal an effect on a serious adverse event. The other kinds of adverse events are very typical of what you see with vaccines: a sore arm for a few days. And then I just want to finish by talking about the fact that the vaccine is only one of the tools we have in our COVID-19 prevention toolbox. We still need to do hand washing, wearing a mask, distancing, which Dr. Moore is going to talk about, and certainly what we have to continue to practice in the hospital environment. The biggest problem that I faced in my viewing and looking at the science and moving it along in COVID is this. Social media is just not a good thing. It allows too broad a broadcasting of voices that lead to problems of polarization, this us versus them mentality. The collectivism of the spring has changed. We've got arguments about masks and no masks, droplets and aerosols, schools open, schools closed, business open, lockdowns. And really, this is really making it hard to sort of move on quickly. Finish off by digging out this article, which was published over 100 years ago in Science by George Soper, who was a major in the U.S. Army, talking about the Spanish flu in 1918. They said he laid out 3 factors that stood in the way of prevention and control of the pandemic. And number 1 was public indifference. And we're certainly starting to see some of that emerge. Hopefully we're going to keep it held off until we get to the bottom of all this. So my 5 big lessons that I've picked up is that science doesn't always move slowly. We know so much more about this virus a year later. However, as stated by Dr. Walker, we're failing the vulnerable. We know supply chains for things like vaccines and PPE is a problem. The hospital has now got virtual visits, this transformation. But this is one of the big things. Delayed consequences enable bad behavior. When we don't actually control behavior by recognizing our consequences, I think we've allowed some of this to kind of proceed on. And then my last thing is just to quote Mike Ryan here, who said, "Perfection is the enemy of the good." So this is my excuse for making a few mistakes a year ago when we knew very little about the virus. And I'll kind of leave it at that. This is my scorecard. This is my summary slide from last year. I got some stuff wrong, and I got some stuff sort of right. But I'm going to leave it at that point and turn it back over to you. This is the other slide I had, and I just flipped it around because it pans out now, well, coronavirus needed more attention than seasonal flu. So I'll stop at that point and stop sharing. Thank you, David.
Thank you very much, Gerald. It's very comprehensive, and you may notice on the Q&A some questions coming in. So if you have time, while it's difficult not to listen to Kieran, but if you have time, you might have a stab at 1 or 2 of those. And with no further ado, we will hand over to Kieran. Kieran, you're on.
Well, thanks. It's very difficult to follow, Gerald, as usual. I just had some short comments, basically, hopefully appealing to the policy audience and referring back to the article that Gerald had mentioned from from May 30th, 1919. Just to quote it, "The pandemic, which has just swept around the earth, has been without precedent. There have been more deadly epidemics, but they have been more circumscribed. There have been epidemics almost as widespread, but they have been less deadly. 3 main factors stand in the way of prevention. First is the public indifference." And I think Gerald approached that. We all have to be united in terms of our knowledge, attitude, beliefs, and behaviors and changes in behaviors. And whenever globally we've seen risk communication be faltered and political leadership not support public health measures, they've had a rise in infection. So we've been lucky in Canada and Ontario to have consistent messaging from our political leaders, both federally, provincially, locally, that have endorsed public health measures. And because of that, our country has done relatively well, especially in comparison to our southern neighbors. So that's always been the difficulty with public health, is learning how to modify, change knowledge, attitude, beliefs, and behaviors. It was difficult back in 1919, and it certainly remains difficult now. And there will be obviously lessons learned in how we can do that more effectively. And then in 1919, they clearly didn't have as firm an understanding of how the virus spread at that time, but took public health measures and closures to try to limit the spread. I'd also just like to report, to read to you some documents from the evaluation of previous events in Ontario. And I'm wondering if you can guess from what report I'm referring to and who was the writer. Therefore, basic public health and core infection control need to be thought of in the lights as function that reflects the social contract between the public and its government, and not simply as another fiscal pressure on a burdened health system. Even in an era of financial and fiscal restraint, we must remind ourselves and others of the cost of ignoring the essentials of public health matters and measures. A key opportunity for comprehensive public health renewal remains, as it has always been, at the local level, where resources have had the greatest impact and where the day-to-day strengths and weaknesses of our system are felt in communities. Ontario should flow from recognizing the need to strengthen basic functions in public health, such as infection control, surge capacity, and emergency preparedness and response in partnership with the overall health system. This was from our beloved Dr. David Walker in the Walker Report from SARS, and I hope some of the policy recommendations that are recommended in this call for action, plan for action, resonate today. It appears we don't always learn the lessons of the past nor apply them. And as you may recall, public health was in a process of modernization at the time of this pandemic. There have been, the third paper I'd like to quote from is, well, I'm going to let you guess. There have been many calls to strengthen public health infrastructure in Canada over the last decade. For example, in late 1993, given the global spread of HIV, Health Canada organized an expert working group on emerging infectious diseases, quite relevant. This Lac Tremblant group called for a national strategy for surveillance and control of emerging and resurgent infections. Reminds us of GFIN, the Global Public Health Information System that was developed in Canada for WHO, that was lost its funding, lost many of its experts and leaders. Support and enhance public health infrastructure necessary for surveillance, rapid laboratory diagnosis, and timely interventions for emerging and resurging infections. Coordination and collaboration in setting a national research agenda for emerging and resurgent infections, and most importantly, a national vaccine strategy. Clearly that resonates today, given that we don't have any of these vaccines at present manufactured in Canada, and we're suffering as a result in terms of access and availability and timeliness. A centralized electronic laboratory reporting system to monitor human and non-human infections, so a One Health approach, and strengthening the capacity and flexibility to investigate outbreaks of potential emerging and resurgent infections in Canada. Another quote from this paper, what I think is relevant to our policy discussion, is a great many systematic deficiencies occurred in the response to this outbreak, and they were identified by the committee, and we went as it went about its task. Among these were the lack of surge capacity in the clinical and the public health systems, difficulties with timely access to laboratory testing and results, absence of protocols for data information sharing among levels of government, uncertainties about data ownership, inadequate capacity for epidemiologic investigation of the outbreak, lack of coordinated business processes across institutions and jurisdictions for outbreak management response, inadequacies in institutional outbreak management protocols, infection prevention and control, lack of knowledge and skills, infectious disease surveillance, and weak links between public health and personal health systems, including primary care, institutions, and home care. So if you didn't guess, the quote from that was from the Naylor Commission of 2003, which reviewed the federal response to SARS. It is sad when we look and reflect upon their recommendations, both from the Lac Tremblant in 1993, as well as the Walker Report, as well as the Taylor Report, that many of the issues that they identified resonate as we will review the public health and health system response to COVID-19 in our communities, locally, provincially, and nationally. Certainly from a policy vantage point, we have seen governance issues, jurisdictional issues, and differences in approach across provinces where at times, there is a politician that's responding and speaking on behalf of the government and their response, or, for example, in British Columbia, where you have the medical officer of health, the chief medical officer of health, Bonnie Henry, speaking and holding a leadership issue. And I think we'll have to reflect and learn what is the best model for governance of public health, what is the best model for leadership, and having spokespeople with expert training in risk communication as your leaders and spokespeople. There's certainly issues on surveillance, whether it's from the WHO and the immediate detection of the virus circulating in China and its communication to the WHO. There's certainly emergency preparedness. It appears, sadly, as an emerge physician, not to have or be a priority. And I always thought we should have a pandemic lead at provincial government and as the federal government. And exercises should be done at a national, provincial level yearly. And we're all held accountable for our plans and our response. And we game and tabletop all of our potential responses and are held accountable to the legislatures for that. Clearly, the recommendations from the Walker panel and the Naylor panel did not occur in terms of emergency preparedness. I am very pleased with our laboratory systems, our ability to introduce PCR testing and increase the availability of PCR has been remarkable. And certainly locally, the communication, collaboration, coordination between assessment centers, the laboratory system, and public health has improved dramatically as well. The question from a policy vantage point will always remain, what is the best model for public health? Should we be integrated within a regional health authority? Should we be linked or accountable within a local health integration network? I think the jury's out, but there'll be multiple recommendations at the end of this. And certainly on the modernization of public health, what is the right size of a health unit? I do think smaller health units in Ontario have been more nimble, more responsive, are typically better connected to their communities and their health systems, and hence can coordinate response much more effectively and efficiently. When you get into large urban settings, the complexity increases dramatically. But I do believe in the strength of being integrated with municipal partners, as well as having a certain size of health unit, whether it's 400,000 or less, leads to a very nimble response. As I said first about risk communication, it is so variable, and when you don't have the best risk communicator speaking on behalf of your community, there can be discordance, and we've seen that in Brazil. We've seen that certainly in the United States, and when you have people who just won't adhere to the right behaviors to limit the spread of the virus, you won't get a significant change in behaviors at a population level. And it's I'm, as Gerald has said, in awe of the immunization strategy and the rapidity of which we have highly effective and safe vaccines at our fingertips. Our phased approach will be rolling out very shortly. And there's governance issues associated with vaccine management as well, but I'm happy that we have clarity now that public health at a local level will be running the strategy at the local level and reporting centrally. And I think that we'll have a very smooth rollout as soon as the supply chain improves. The other last thing I just want to talk about was public health measures. We've seen globally variants on how these are applied, but we're all trying to share the science on public health measures. They always have to follow what we teach in our PHPM program, a Neufeld's ethical ladder, where you move from the least coercive to the most coercive. You start with education, and then you work your way up from educating individuals about best behaviors and means by which they can protect their families and themselves. But then you have to be able to have enforcement. You have to engineer success, like plexiglass and hand hygiene products being available and accessible. And then, if necessary, economic penalties and incentives and disincentives. And I think we've done a decent job of having consistent approaches across Canada on progressive, evidence-based public health measures that follow that Neufeld's ladder of going from least coercive to most coercive. And certainly now that we have variants of concern circulating in Ontario, we may have to have ongoing public health measures. But at least within Ontario, we have Public Health Ontario, which is our scientific advisors to local public health agencies. And thank you, David, for stimulating the creation of that agency and being its first board chair. That agency is providing all health units and government with evidence to support the decision-making and is a remarkable improvement, what we didn't have 20 years ago. And I salute them. I salute their laboratory capacity, which is absolutely internationally renowned, and their ability to adopt PCR testing as compared to what occurred in the United States and the CDC launching of their PCR coding it is remarkable, and their ability to ramp up really has allowed public health to be able to detect, respond, and prevent further spread in our community. So I just was raising those as policy issues, and I'm happy to transition over to Sam, one of our PHPM residents from soon to be graduating from Queen's University.
Thank you very much indeed, Kieran, and thank you for all you're doing to keep us all safe. Over to Sam.
All right.
Welcome, Dr. Buttemer.
Thank you. I'm just going to share my screen here when I get it set up. There we go. So today I'm taking on the topic of who's really impacted by COVID. We've all spent a lot of time talking about COVID over the past year. It's one of those things that you can't really go a day without speaking about at this point. But there are some of us that are disproportionately impacted by the virus and the pandemic and the actions of the pandemic. So I've heard this repeatedly through a variety of sources in media, politicians, people trying to call us all together, saying, you know, this is hard, but we're in this together. We're in the same boat getting through this pandemic. And if there's one thing that I've seen in the data that has come out since early 2020, it's that as a society, we're not equally sharing the burden of the storm. The first group that I think you can't talk about COVID without talking about this population is individuals in care settings in our country. Individuals living in long-term care, retirement homes have a dramatically disproportionate number of deaths, of risk of infection, and particularly for-profit nursing homes have dismal outcomes with regards to deaths and outbreaks. It is becoming clear that basic personal protective equipment is necessary for staff working in these environments. We can't have staff moving from job to job. However, many of the individuals working in long-term care settings don't have full-time hours, and so they have to cobble together part-time positions, and that increases the risk of transmission. Also, they're fairly low-paid positions, which we know that individuals of lower income are disproportionately being infected with COVID at least in Ontario. And so all of this comes together to create a perfect storm, because the host, the individuals being infected in long-term care are so incredibly vulnerable to severe illness and mortality. And so you have this perfect storm where you have people spreading disease and people that are vulnerable to getting disease in society, bringing it into these vulnerable settings with the lack of resources for a long time standing with regards to infection prevention and control, IPAC procedures, and basic outbreak management. There's been guidance on outbreak management for quite a long time in terms of respiratory illness in long-term care settings. It's available on the ministry website, but it's still something that people have, institutions have struggled with for a long time. And it's highlighted here that there's dramatic impacts on those long-term care homes where the procedures are not well established. The other harm faced by this group is the isolation associated with COVID. You have individuals who are living in these settings who are unable to see their loved ones, unable to see family, and have a difficulty using technology or connecting in other formats. And we had we didn't really acknowledge that unpaid caregivers, like loved ones, were providing such an essential service to individuals in our care settings, and to leave them out was harmful in a substantial way. I'm thankful that provincially our vaccination strategy is targeting essential caregivers as part of the priority group, but it really exposed weaknesses in our system that have been sitting there for a long time. The next group that you really can't ignore are people who have other problems. I'll give you an example of this. I have a good friend who lives in the US, and she heard in May that one of her close friends, a man in his mid-30s, had died. And an autopsy was done, and it was found that he had appendicitis that had ruptured, and he hadn't gone to hospital. And he didn't go to the hospital because he was scared of COVID. He was scared of going to the emergency room and getting sick. And he was all the data that we had around COVID at that time and the information that was being shared in the media was saying, stay home, don't go anywhere. And there are people that internalize that deeply. And it meant that they didn't access care when they needed it. And we have disproportionately faced morbidity and mortality associated with that. We also know that individuals in hospital, again, face the same problems in long-term care. They're unable to have visitors. And so many individuals older individuals in particular, are prone to things like delirium. And if they don't have family members there to help keep them oriented, it can make those problems worse. And so we've faced individuals in a very difficult time in their lives. Illness is challenging, unable to have love and support from their families during COVID. And then you have to dig a little deeper and think about all the people we don't know about. And I personally fear this on a societal level in terms of the burden of illness that we haven't been capturing through our preventive mechanisms and our usual mechanisms for investigating illness. In Alberta, the number of cancers diagnosed between March and September of 2020 was 23% lower than the same period the year before. And it's not that there's 23% less cancer. Almost certainly the cancer rates are not really changing that dramatically year to year. It's that people weren't presenting to their family physicians, they weren't presenting to Emerge, and they weren't presenting to screening programs like the breast cancer screening program, or getting their PAPs, or getting their FIT or colonoscopy done for colon cancer. In British Columbia, the same trend, new diagnoses dropped about 20%. At Princess Margaret Hospital in Toronto, referrals for chemotherapy for breast and gastrointestinal cancers over the summer were down 38 and 40% respectively. And those cancers aren't gone. And they're going to present later, which comes with more morbidity and mortality for the individuals that have them. And there's also going to be a bubble, right? We're going to have a bigger group of people that require treatment at the same time, which could then change wait times for everyone. This doesn't even get to the idea of around essential surgeries being delayed. We often talk about elective surgeries being delayed, but cancer surgeries are often elective surgeries. Elective doesn't actually mean that you don't need it. Elective means that you don't need it, within 5 hours or 20 hours or something like that. We have a little bit of wiggle room to play with, but we don't have that much. And it will be telling to see whether there are differences in outcomes for people who have had their surgeries delayed in centers that had to close elective surgeries due to surges versus areas that have been able to maintain their surgical volume. And that's going to be data that needs to be looked at over the next few months to a year. So in general, we've seen excess deaths through the pandemic, but those excess deaths are actually not all COVID related. COVID definitely plays a role. There is excess death period over the time period than we would expect, and many of those are COVID related deaths, but many of them aren't. For example, from mid-May to mid-October, there was an excess of almost 1,400 deaths in Canada. Males accounted for 81% of those deaths. And this was predominantly in Alberta and British Columbia, and both provinces have noted significant increases in overdose deaths over the past year. And so in particular, we're seeing deaths in people, younger males, right? So individuals that we don't have the data to say for sure that it was overdose deaths, but there's a good chance that overdose deaths play a significant role in this outside of just infectious disease. So when we talk about the deaths associated with COVID, there are some people saying things like, it's predominantly affecting older population, it's not as big of a deal, but it's actually the pandemic itself and the measures that are in place with the pandemic and the attention that we've put on the pandemic has and will continue to result in excess deaths across society. Women and children also face a significant burden. And particularly when talking about women, there has been a regression in terms of equalities that women have worked for decades in terms of economic equality. Women face disproportionate economic impacts due to pandemic actions because of existing economic inequality. So they're already in a more vulnerable financial position. And we know that individuals that are, there's a widening gap between the people who are rich are getting richer during the pandemic and the people who are poor are getting poorer. Women hold jobs that are more vulnerable to loss in the pandemic. So more likely to be working in retail services, food services. And we don't really have an idea of the burden of this at this point, but we also know that violence against women is a significant issue in homes across the country. And with stay-at-home orders, it can be deadly for people who live in unsafe circumstances. Women also take on the disproportionate burden of family care and child care. And I have friends who've told me stories of trying to work from home while they're caring for their children and doing virtual school for their children at the same time. And it's just untenable. And so are these women going to be applying for promotions? No, they're treading water, trying to get through the next day. Children are also disproportionately impacted by the interventions that we've put through. We know that education improves lifelong outcomes for individuals, both in terms of health and in terms of income. And we don't know what closures of schools will do to those outcomes down the line, particularly for the most vulnerable children in our society coming from lower income households who are already disproportionately impacted by things like poverty. These children are unable to access things like food programs that are available at schools, so their nutrition can be suffering. Virtual teaching is not equal across the country. If you don't have a parent to help you with the computer, it's very difficult to engage in virtual teaching. Children who have different learning needs and things like ADHD, it's very difficult to manage online learning in an effective way, and they're being left behind. There's also been rates of, domestic violence and violence against children in the home have been shown to increase in studies that have been done worldwide. So we don't know the harms yet that children are facing with this. And I think it's going to be something that we need to follow for years to decades. But I think it's naive to think that children aren't bearing a significant portion of the suffering in this pandemic. I haven't even touched on the mental health impacts. We talk a lot about children being resilient, and it's true, they are resilient, but I think we need to be careful and try to preserve our institutions like schools as much as possible. And the best way to keep schools open is to keep the community burden of illness low otherwise. Schools, should be the last to close and first to open. And thankfully, we've been able to reopen our schools here in KFLNA, but that's not the case across the province. And I worry for people living in communities where schools have had to remain closed. Shifting now to racialized populations, they face a disproportionate impact of disease and disproportionate rates of infection. We know that the rate of COVID-19 infections in the most diverse neighborhoods is 3 times higher, at least in Ontario, than the rate in the least diverse neighborhoods. And those individuals living in the most diverse neighborhoods are more likely to experience severe outcomes. Their rates of hospitalization are 4 times higher. ICU admission rates are 4 times higher. Death rates are 2 times higher. That is a tangible dramatic impact on racialized populations in our country. And it's partly due to existing structural and societal racism that has led to health stresses leading to things like the development of diabetes, hypertension, obesity, that all increase the likelihood of severe illness. We also know that individuals from these communities might, because of poor historical treatment in healthcare settings, they feel lack of trust and will avoid accessing services. There might be disproportionate access to vaccines in that people don't feel safe getting vaccines, again, because of this historical lack of trust. And we need to consider the impacts of our racist practices across the country and how that is impacting people with regards to COVID. And finally, the last population to speak about who are facing a dramatically different pandemic than people like me who have the privilege of sitting at my computer and working from home are individuals that are dealing with poverty. Nearly half of the COVID-19 cases in November in Toronto were among those living in households considered lower income, even though they only make up 30% of the population. These people lack often protections in work to allow them to stay home when sick in order to reduce transmission of disease, and they hold essential jobs that are required in society, things like our warehouses, our grocery stores, our PSWs. They don't have a choice. They need to go to work, otherwise they risk losing their job, and so they're putting themselves at risk day to day going to work. Taxi drivers as well. I've heard stories. There's also issues with people who lack housing. Ontario's homeless was found to be 5 times more likely to die of COVID-19 than a non-homeless individual. And that's a huge difference in risk and complete inequity. Individuals living in neighborhoods experiencing the highest level of material deprivation, which is an index of poverty, are more likely to experience severe outcomes with 69% higher hospitalization rates, again, 2 times higher ICU rates, and death rates just over 50% higher. The pandemic has dramatically widened, again, the gap between the rich and the poor in terms of income, and we're seeing this play out both in COVID deaths, but we know that poverty worsens health outcomes long-term, and this is not helping us work towards equality. So COVID-19 has exacerbated the inequities in our society, and I think we need to spend some time reflecting on that and what we can do societally from a policy level to make changes so that this is not the way we move forward as a society. Thanks so much.
Thank you very much, Sam. Time is nearly up, and I thank all 3 of you very much for this. We have had a number of questions. I think nearly 30 questions have been posed, and thank you those who've been, I see 13 have been answered. Just in the couple of minutes left, I would ask the question, rapid testing. We see many jurisdictions, and certainly the private sector, engaged in rapid testing, presumably rapid 15-minute antigen testing before you get on a plane or go to work or go back to university or something. Gerald, what's your thought on rapid testing and its evolution?
Great question. So let me do this in about 15 seconds. So the problem with rapid testing is it's not as sensitive as lab-based PCR testing. And it's also important to remember that testing is a snapshot in time. You were negative that day, but who knows if you're going to be positive tomorrow. Having said all that, having had all the misgivings about the technology, if you do a lot of testing, massive testing, with rapid tests that are less sensitive, you're still going to get a benefit from it. And my colleague, Michael Mrna at Harvard, has been a big proponent of pushing for widespread rapid testing. But there are limitations. You have to use it in the correct setting. Right now, my view is that the best setting for using rapid tests is in schools. You've got a low pretest probability population in school-age children. So the test is going to have the least bad impact of a poor negative predictive value. And it will find positives and keep them out of the mix. So rapid tests, they're not a panacea, but there is a role for them, and you just have to find that role perfectly.
Thank you very much. Question for Kieran. You sent inspectors into long-term care long before others did. Very quickly, could you explain, there was a question, why the difference in terms of morbidity and mortality in long-term care on those who work in long-term care versus hospitals? In a nutshell, what was the difference?
Well, there was also one question about pandemic preparedness. Yeah, KFLNA has done regular pandemic preparedness exercises. Typically, we do them in the summer and bring 100 partners together. And also, every influenza season is a pandemic, and we treat it very seriously and work together with all health system partners, because if you can work on influenza well together, you can work on other emerging infections. Secondly, the issue of supporting our long-term care facilities and retirement homes, we've had a long relationship with them. They're brilliant. They have some of the highest influenza immunization rates. They started off with good infection prevention and control skills. It was our goal to strengthen them, to support them, to provide auditing via a third partner, and to, on an ongoing basis, ensure that they had the skills, the attitudes, the behaviors, and the resources to be able to respond to or recover from any infectious threat, including influenza and or COVID. So it was unique to us. I don't know if any other health unit has done it. It just strengthened our partnership. We meet weekly now with them as we are rolling out our immunization strategy to support them and to, in an ongoing basis, audit their skill sets so that they maintain them even when their immunization rates get high, which we anticipate will happen in the next several weeks.
Thanks, Kieran. I'm going to pass back to Warren because I think we're out of time. We maybe should schedule longer for next time, but I will, on behalf of my friends, promise that 1 year again from this date, we will repeat this and remember what we said today. Warren, over to you.
Thank you so much, David. And thank you to Drs. Buttemer, Moore, Evans, and Walker. This has been incredibly helpful. I think you can see the level of engagement from the audience today. There's lots of questions. Thank you so much for the answers that you're able to give and for your insights. We will look forward to another session on this. We're hoping it'll be a post-mortem and a look back rather than...
Careful with that language. Yep.
Sorry, but a look back, let's put it that way. For those of you that are interested, we do carry on a regular series of conversations about the pandemic and various aspects called Contagion Cultures. Our next session will be next Tuesday at 4 p.m. We have Professor Ali Na, who's going to be speaking about anti-Asian racism from the 19th century to COVID-19. So I encourage you to jump in for that. Thank you so much to all participants. Thank you so much to our panel. Tremendous day and lots of information. And I wish you all the best for the weekend. I hope that the weather stays good. Thanks, everybody. Have a great day.